Hello.
Hello. Hello.
Hello.
Hi, doctor.
Hi, Kushi.
Yes,
Is
yes,
there
ma'am.
any problem with this link?
Exactly, doctor said, but I tried joining from my other device also, and I was able to join, ma'am. I don't know.
Even I joined, but there was an option to join as a panelist. It's not like a panelist link directly.
Okay,
If everyone uses that, I mean, it should be okay thing. I don't know why Ankit is unable to join.
I don't know, ma'am. I will just try to promote everyone so that.
Yeah. That the speaker is not here, no? Yeah, she's not in the group. I don't know if the number. I don't have a number, so I don't know if that.
Even I don't have, ma'am. That's the thing.
Okay.
Like,
Yeah. I mean, she's not joined yet, right? I know. Should I
no,
call
ma'am.
up and ask her? I don't know if that is the number. Her number. This one number 93202. I don't know if it is the
I
same
can't see the
person.
name. Not sure.
We will wait for another 5 minutes and I'll call her.
Yeah.
I think Dr. Mahesh is joined.
Yes, ma'am. He has joined.
Hello.
Hello, Mahesh.
Yes,
I'm
ma'am.
yeah. Hi.
No, ma'am will join in 2 minutes. Hi,
Oh,
ma'am.
yeah. Hi.
She'll join in 2 minutes.
Yeah, sure. So Dr. Mahesh will be introducing Tanu, right? I don't have a CV.
Yes, ma'am. Can you please promote Dr. Tanu to panelist, please? Khushi, hello.
Yes, doctor.
Can you please promote Tanu ma'am to panelist?
Sir, I can't see her.
She's there.
She has joined by which name, sir?
I will ask her, just a minute.
Yeah.
मैं आपको 1 मिनट कॉल कर रहा हूँ. 1 मिनट. Okay, ma'am. Anand something करके. Fine, ma'am. I'll do it.
Oh, I have sent her the
Anand
request, sir.
7 p.m.
I have sent her the request. She has to accept it, doctor.
Ma'am, you have to accept the request. It has been sent to you.
Yeah, now she accepted.
Okay,
She's in
fine.
transition.
Okay, Rajeshwari ma'am, you can start. It's 8:30.
Yeah, good evening, everyone, and welcome you all to the third webinar on Friends of PICU. This is a unique program where we invite friends from other specialities to enlighten us in the field of critical care. Today we have Dr. Tanu Singhal, who will be speaking on MDR infections in critical care. I request Dr. Mahesh to introduce Tanu.
Yeah. Am I audible?
Yeah, you're.
Great. Dr. Tanu, you're there, right? Hello.
Yeah, I'm there.
Great to have you here. First of all, good evening all. It's really a privilege for me to introduce. I don't know how many times I have introduced her so far in my career and in her career. So wherever there is a ID talk, she becomes an obvious kind of a choice to give the talk. And what about her, spectrum of knowledge? We have been hearing her for, I think, like not less than 15 to 20 years, right from the Mumbai and state and the national and international webinars. I mean, whenever there is any, it might be COVID or non-COVID or TB or any bacterial infection, whatever virals, Tanu is obvious choice. She's absolutely updated. She's a senior pediatric ID expert in Mumbai, and she practices Kokilabhen Ambani Hospital. And easily, as I said, she is the choice for any ID related topics. She has been convener to many modules. She has written many textbook chapters, and she has got a lot of research to her credit. I don't have a CV in my hand, but she gives it. Perhaps the whole session will go in her kind of introduction itself. So she's wisely not sent a CV to me, but I know enough, and I'm sure all of you know it. She needs no introduction. She's really a big person in this field, and it's really privilege for us to have her here. And with that, it's over to Tanu for next 1 hour of complete extensive knowledge in MDR infections in PICU. Thank you very much.
Yeah, just give me a minute, 1 minute.
Sure.
Okay. Yeah, so let me just share my screen. Can you see my screen?
Yes,
Yeah,
ma'am.
yeah, we can see.
So actually, I've given a similar talk so many times. I was just looking at my previous presentations, and I think almost every year I give a talk on, PICU pathogens. And so I have tried to make it a little bit more advanced this time, because I think the people who are joining this lecture are intensivists and students who are studying critical care. And it is a little different from my previous talk. So let's hope it goes well. So because I was given this topic of MDR pathogens in the PICU, I first thought I must tell my audience, what do we really mean by these terms? And how actually it would be much better if we would call it drug-resistant pathogens in the PICU. Because if you look at MDR, it means that there is resistance to at least one agent in 3 or more antimicrobial classes. So that means if you, let's say, have E. coli, and that E. coli is resistant to third-generation cephalosporins, it is resistant to aminoglycosides or ciprofloxacin, it will become an MDR. And XDR is basically an MDR which has become even more advanced, whereas there is resistance to all classes except to, and this is what we are really worried about in the PICU nowadays, because we see so many carbapenem resistant pathogens. So they technically come in this category of XDR. So your MDR are mainly your ESBLs, and your XDR is your carbapenem resistant pathogens. And then you have another term which is called as PDR. And PDR means you have resistance to all antimicrobial agents for which susceptibility tests are available, or for the drugs which are currently available in your country. So, for example, you may be able to treat one Klebsiella with cefiderocol, which is a new drug, but that is not available with us. So, therefore, if you have a Klebsiella which is resistant to all drugs, including colistin, etc., then you will call it as PDR. But, earlier we had that term of, TDR or PDR for MTB. Now that term has been given up because more and more new agents are available. So, therefore, also we don't really have a PDR in bacteria as well, and we should mainly talk about MDR and XDR. So I'm really going to talk about these pathogens, and I'm talking mainly about definitive therapy here after the culture report is received, because whenever I have given this talk earlier, I have mainly talked about how to choose your empiric antibiotic in the PICU, and then once you get the culture, how to change treatment. So this time, I'm actually starting with the fact that once your culture report is received, because even after your culture report is received, how you're going to choose the antimicrobial is actually complicated. And I'm going to talk about gram-negative pathogens mainly. So I think 3/4 of my lecture time will be with gram-negative pathogens, where you have all kinds of resistance to cephalosporins, resistance to carbapenems, when you have a pathogen which is resistant to almost all drugs, etc., except colistin poly B, and then maybe we can talk about what to do when you have resistance to even colistin poly B. Then in gram-positive, I will talk about only MRSA. And then if time permits, I will talk a little bit about fluconazole-resistant candida, because that is also becoming an important pathogen in the PICU. And now, even as pediatricians, we really need to know about the echinocandins. So with that introduction, I just want to show you some of the data from our hospital, which was in the year 2021. So these are hospital-acquired bloodstream infections which we had. We had about 20 bloodstream infections over the cardiac ICU, PICU, NICU, 21 isolates. And if you look at this, you find that the most of them are the gram-negative isolates, 80%, whereas you have approximately 5% gram-positive and 14% yeast. So in fact, now the yeast are even becoming more common than the gram-positive isolates. And when you look at the gram-negative isolates, you find that Klebsiella is the most common pathogen, which is what you all would be seeing. And after Klebsiella, you have E. coli and you have Acinetobacter. And then maybe you have Pseudomonas, Enterobacter, Serratia, etc. And now you also might be seeing very unusual pathogens in your PICU, names which you have never heard about before, like Stenotrophomonas, Chrysobacterium, etc. And all these agents are coming in because we are using a lot of antibiotics and we are using a lot of colistin. So the reason to show you this is that most of us will really mainly encounter resistant gram-negative pathogens in your PICU, and less commonly gram-positive agents. And whatever gram-positive agents you will get, probably you will get in patients who are coming in with severe community-acquired infections where you have got an MRSA or something. Otherwise, as hospital-acquired, you might see vancomycin-resistant Enterococcus, which you have to treat. So that is why I'm really going to talk about gram-negative pathogens. Now, before we talk about gram-negative pathogens, we must understand the resistance mechanisms here. And I know most of you who are listening to this lecture already know this classification of resistance, but this is just a kind of a kind of quick revision so that we are all on the same page when I'm talking about different kinds of resistance enzymes. So these first generation beta-lactamases are the ones which are produced by a wide variety of organisms like Staph aureus, E. coli, Hib, Moraxella, etc. And these lactamases inactivate amoxicillin or penicillin. So the drugs which are effective against these first generation beta lactamases are your cephalosporins, your clox, and amoxiclav. So this is not a concern. So we are not really going to focus on these organisms when I'm going to discuss gram-negative resistant pathogens. And then you have ESBL. Again, ESBL, all of us know they have been around for almost like 30 to 40 years now. And they are mainly produced by E. coli and Klebsiella. And they inactivate your cephalosporins, your penicillins and aztreonam. And therefore, the drugs which we commonly use for treatment of ESBL infections are your BL-BLI combinations like piptazo, cefoperazone, sulbactam. Remember that though amoxiclav is a BL-BLI combination, it does not work for ESBL. And therefore, if you see a culture report which says that ceftriaxone is resistant and amoxiclav is sensitive, please don't use amoxiclav because that may be a false sensitivity. And of course, we have carbapenems which work well for ESBL. Then you have your AMP-C beta-lactamases, and the common organisms which produce AMP-C are Pseudomonas, Serratia, Proteus, Citrobacter, Enterobacter, somewhat which are called as spice organisms. And as pediatricians, we are really concerned about, Citrobacter, because you've often seen newborns coming to you with severe meningitis due to Citrobacter. Then we see Enterobacter also as a pathogen. And these organisms produce so much of beta-lactamase that the beta-lactamase inhibitor, which is present in your BL-BLI combination, will not be able to take care. And therefore, the drugs which can take care of AMP-C production are carbapenems. And of course, now you have a new beta-lactamase inhibitor called avibactam, which also works for AMP-C, and we will discuss about ceftazidime avibactam also in this talk. And then you have cefepime, which is stable against AMP-C. But remember, when we talk about the organism, it is not going to produce only one type of beta-lactamase. So you will have an organism which will produce ESBL also and will produce AMP-C also. So if you use cefepime, though the cefepime may be stable to AMP-C, it will be destroyed by the ESBL. And really, in our clinical practice, we cannot really determine what are the kind of enzymes which are being produced, which we do not have in day-to-day practice. So one way to know whether AMP-C is being produced or not is to see your report. And if your E. coli shows that it is sensitive to carbapenem, but it is resistant to BL-BLI, then it may mean that it is an AMP-C producing organism. And then what we are really concerned about is the carbapenemases. And these carbapenemases are produced by lots of bacteria, including your E. coli, Klebsiella, Pseudomonas, Acinetobacter, etc. And these inactivate the carbapenems, and therefore you have to use other drugs like colistin, poly-B, tigecycline, phosphomycin, and the newer BL-BLI combinations like Cas-Avi or ceftazidime avibactam for these pathogens. Now, one must also remember that, as I said, that one organism can produce multiple beta-lactamases, and also the organism can become resistant by many mechanisms. So it's not that a gram-negative pathogen will become resistant only by production of these enzymes. It can have probably a problem with the porin, so the drug cannot enter the cell. It can have an efflux mechanism by which the drug leaves the cell. So these are other mechanisms, and these mechanisms are particularly more common in Acinetobacter and Pseudomonas as compared to E. coli and Klebsiella. So your E. coli and Klebsiella mainly become resistant by these beta-lactamases, whereas your Pseudomonas and Acinetobacter become resistant by production of beta-lactamases as well as by other resistant mechanisms. So with that I again want to show you some of our data for the year 2021 about our gram-negative isolates in our NICU, PICU, and pediatric cardiac ICU. So you see that, ciprofloxacin doesn't really do well. Then if you look at piperacillin tazobactam, which was supposed to be a very good drug, but in our ICU, the susceptibility has really dropped. And therefore, and this is also the same thing which is being seen in other ICUs. Of course, if people are in smaller ICUs where there's not too much of drug use, or they are not getting patients referred from other hospitals, you may have better susceptibility. The other thing which is remarkable in this chart is that your sensitivity to imipenem and meropenem is almost the same as it is to piperacillin tazobactam. That means, because sometimes what happens is that when your patient is or not doing well on piperacillin tazobactam, you say, okay, let us upgrade to meropenem. But understand that there is not too much of difference between pip/tazo and meropenem. So it's so you when you're giving either piperacillin tazobactam or you're giving meropenem, if the patient is not doing well, you have to go to a colistin based regime. That is something which you really need to understand. And another thing which you can see from this chart is actually that the aminoglycoside susceptibility is far superior to meropenem, imipenem, piperacillin tazobactam, etc. And that is why it is becoming an important drug for us again. Now, if you look at tigecycline susceptibility, you think, oh God, it's a good drug. But remember that this tigecycline susceptibility has been calculated thinking that the MIC cutoff is 2, because that is the standard cutoff that we use. But when in real terms, if your tigecycline MIC is 1 or is more than 1, tigecycline will not be successful. And therefore, you should not just look at the susceptibility report, but you also have to look at the MIC. So before you actually choose a particular drug, and we will discuss that in some of the cases as we go along. So based on the current sensitivity pattern, I have made a kind of hierarchy of drugs for gram-negative pathogens, and this is not from any kind of reference. This is my own kind of what is my understanding. So in your first level, you have these drugs like ceftriaxone, amoxiclav, ciprofloxacin, etc. Then your second level is your BL-BLI combinations, including cotrimoxazole, etc. Then your third level is actually your carbapenem and amikacin, and maybe sometimes amikacin should come maybe to the fourth level. And then in your fourth level, you have all these other drugs like colistin, tigecycline, fosfomycin, ceftazidime, aztreonam. These all are the fourth level agents. So whenever you think about hierarchy of drugs, then you should probably keep this table in mind. So with that, I'm going to be presenting 3 or 4 cases in my talk today, so that you can try and relate the choices of antibiotics to real case scenarios. So this is a 3-year-old girl who came with fever for 3 days with no focus. She had a temperature of 104 degrees Fahrenheit. She was tachycardic. When she was seen in the ER, her capillary refill was 4 seconds. Her extremities were cold. The chest was clear, and she was admitted to the PICU because it was thought that she has features of early septic shock. Of course, you must understand that if the child is very febrile also because of peripheral vasoconstriction, you may get prolonged capillary refill and cold extremities, but this patient was admitted to the PICU. And this patient had not received any antibiotics previously. So all her cultures, etc. were sent, and she was started on IV ceftriaxone. She was also given fluids and antipyretics. And when her reports came back, the white cell count was high. There were 86% polys. The CRP was quite high, and her urine routine had 60 pus cells per high power field. So obviously, we are dealing with a case of a severe urinary tract infection with maybe early septic shock. Now, this patient's fever continues over the next 2 days, though the general condition becomes better. And then after 48 hours, you get the blood and urine culture, which both grow E. coli. And we know, because we know that E. coli is the commonest pathogen in urinary tract infection. And what was important is to look at this sensitivity, which is ceftriaxone. And it says that ceftriaxone is resistant. And if you look at here, amoxiclav shows that it is intermediate susceptibility. So please don't get fooled by this. As I said, that if ceftriaxone is resistant, it means it's an ESBL pathogen, and then you can't rely on amoxiclav for treatment. Now, if you look at this, then you have various drugs. It is sensitive to the carbapenems. It is sensitive to piperacillin tazobactam. It is sensitive to cefoperazone sulbactam. It is sensitive to TIGI, of course, which should not be repeated for a urinary tract infection because TIGI doesn't go in the urine. So you have a lot of options. And basically, this is an ESBL E. coli infection. And I've just put the Vitek chart also in front of you, because if you look at the MICs, you may not be able to read it well, but I'm saying this, that cefoperazone sulbactam, the MIC is 8. And we know that for cefoperazone sulbactam, the break point is 16. So it is sensitive. Then if you look at your meropenem MIC, the meropenem MIC is 0.25. That means it's very, very sensitive. And if you look at your piperacillin tazobactam MIC, it is 8. And if you look at the break point, again, the pip-tazo break point is 16. So that means it is also sensitive. Now, So now if you have this culture report in front of you, basically you have to decide that, okay, I will need to change antibiotics for my patient because the patient is not getting better. Of course, sometimes it may happen that you have a patient who you've treated with ceftriaxone and the patient gets better, even though you may have a report like this. Because as you know that there is a difference between in vivo and in vitro susceptibility. But this patient did not get better, so obviously you have to change treatment. So the question which is there in your mind is that now that you're dealing with an ESBL pathogen, what are you going to switch to? Will you add amikacin to the ceftriaxone because amikacin is sensitive? And then you think that in this patient, once the patient is better, when I discharge this patient, I will continue amikacin once a day. Will you go to a BL-BLI combination in this patient? And if you decide to give a BL-BLI, again, you have to choose which one because you have piptazo, you have cefoperazone, sulbactam, or are you going to go to a carbapenem in this patient? So for treatment of ESBL, how do you choose which drug you are going to use? So when the most important consideration in your mind is to choose between BL-BLI versus carbapenems. And there have been lots of meta-analysis and cohort studies which showed that BL-BLI combinations are as good as carbapenems, because earlier it was thought that if you have an ESBL infection, you have to use carbapenems only, and that was the evidence coming out of the US. But now then came a lot of meta-analysis which showed that they were comparable. But what actually changed things was the landmark Merino trial, which was actually an adult trial, which they basically treated adults who had complicated UTI with ESBL, E. coli, bacteremia, and they showed that the mortality benefit was better with carbapenems as compared to piptaz. So when they looked at, even though piperacillin tazobactam was sensitive, they still found that carbapenems work better. So how will you choose whether you will give a BL-BLI or a carbapenem? It will depend on the degree of sickness of the patient. So for example, if you have a patient who's really sick, who's in septic shock, who has a high bacterial load, then it would be more prudent to use the carbapenem because we know that BL-BLIs are susceptible to the inoculum effect. Then also it will depend on source control. So for example, you have a patient who comes with intra-abdominal sepsis, appendicitis, and you have done a surgery and you've removed all the pus. Then you can use a BL-BLI. But if you've not been able to do source control, then your bacterial burden is high and you will use a carbapenem. It will also depend on the host comorbidities. So for example, you have a neutropenic patient who has come to you with sepsis and he has grown an ESBL pathogen. Then you might be more inclined to use a carbapenem because the patient's own ability to fight off with the infection is less. And also, finally, you will look at the MIC of the BL-BLI combination. That is also very important because if you have a relatively high MIC, even though the organism is susceptible, you may want to use a carbapenem. And I will come to that a little bit later. So which BL-BLI? So suppose in our patient, we thought that this patient is not in septic shock now, this child is relatively stable, so I can use a BL-BLI. Then you have to choose which BL-BLI because there's so many of them. So when you talk about piperacillin tazobactam, it is the most commonly used drug because there's maximum experience with this drug. It also covers your Enterococcus faecalis and it covers your Staph aureus, MSSA also to a certain extent. Because many times when you use empiric therapy, this is a definitive therapy, but when you use empiric therapy, you really don't know what the agent is. So if you use piptazo, you do cover your MSSA also to a certain extent. Then when you compare the beta-lactamase inhibitors, you have tazobactam versus sulbactam. So we know that tazobactam is better for inhibiting CTXM, which is a major ESBL which is being produced in the Indian setting. You have a lot of PK/PD studies which are available for piptazo. However, one drawback of piptazo is the sodium load. The other thing which you must understand is there is a dichotomy between the CLSI and EUCAST breakpoints for Enterobacteriaceae. Now, because you know that for defining an organism as sensitive or resistant, you have to use certain guidelines. So you have the CLSI guidelines, which are from the US, and you have UCAS guidelines, which are from the Europe, and you have a BSAC guideline, which is from Britain, which we don't really look at. Now look at the CLSI guidelines. For CLSI, your piptazo, if it is anything sensitive is anything 16 or less, intermediate is 32 to 64, and resistant is more than 128. Whereas if you look at UCAST, the sensitive breakpoint is 8, whereas 16 or more is resistant. Now, why I'm saying so is that suppose your PIPTAS MIC is 16. Then if you don't look at the MIC, the report which your lab gives will say that PIPTAS is sensitive, because all our labs look at the CLSI breakpoint. Whereas if you look at the MIC as per UCAS criteria, it will become resistant. So that is why you have to be very careful. You have to look at the MIC. Now in our patient, our MIC was 8. If MIC is 8, it still becomes susceptible only, because even by UCAS criteria, it is susceptible. But there are some studies which show that if your piperacillin tazobactam MIC is more than 4, then the chances of failure are high. So always, when you're deciding to use PIPTAS, please look at the MIC and then decide whether you want to use it. Now, the other drug which you can use is cefoperazone sulbactam. The problem with cefoperazone sulbactam is that it is not US FDA approved. So there is not much information about this drug. There are not many trials which have been done. There are no breakpoints, and therefore the breakpoints which the lab uses are those for cefoperazone. It can also cause hypoprothrombinemia, and therefore if your patient is on cefoperazone sulbactam, you have to make sure that you are checking the PT-INR and giving vitamin K supplements if needed. One more advantage of cefoperazone sulbactam is that it has some better activity against Acinetobacter, because sulbactam itself has inherent activity against Acinetobacter. And the other advantage is that it can be given twice a day, and that helps you in outpatient therapy. So that means if you've started cefoperazone sulbactam in the hospital, then you can change it, continue it at home. Whereas if you're giving PIPTAS, you have to give it 8 hourly. Now, other BLBLIs which are available are, for example, you have cefepime tazobactam, for which there is in vitro data is promising, because what they thought is that if you use cefepime tazobactam, it will take care of AMSI and it will take care of ESBL. But we don't have clinical efficacy studies, and we know that cefepime is associated with an increased risk of seizures. Then there is this new BLBLI combination which is called as ceftriaxone sulbactam EDTA. And here, EDTA is basically helpful for an NDM infection, and it also acts as an antibiotic resistance breaker. And there is a proper trial which shows that this BLBLI is non-inferior to meropenem. So basically, this BLBLI is at a level higher than piptazo and cefoperazone sulbactam, probably at the level of carbapenems, and in some patients it may also be used to treat carbapenem-resistant bugs. And ceftazidime avibactam is clearly a BLBLI which is above the other BLBLIs, and we will not waste it for treatment of ESBL. And remember that when you are using BLBLIs, please use higher doses. Like the maximum dose of cefoperazone sulbactam in adults is 3 grams twice a day. So you have to dose it as 100 milligram per kg of the ceftriaxone component, because sometimes what happens is you write the dose and the nurse gives it as the total dose. Because suppose you have cefoperazone sulbactam, you have 1 gram of cefoperazone with 500 milligram of sulbactam. So if you write 1 gram of cefoperazone sulbactam, you actually give the patient less cefoperazone. So please remember to write the doses in terms of the beta-lactam component. And you have to give more frequent doses, and continuous infusion may also help in overcoming relatively high MICs. And as I told you, for cefepime, it's not a good drug, and your lab may often report cefepime as sensitive because we follow the CLSI breakpoints, where anything 8 or more is resistant. But and therefore, if your MIC is 2, the lab will report it as SDD. And SDD means it may not, cefepime may not work. So again, you will have to look at the UCAST breakpoint. So if your cefepime MIC is 1 or less, you can use it. Otherwise, you can't use it. So that was that discussion of choosing a BLBLI for ESBL. But let us say we want to use a carbapenem. And because our patient is very sick, the patient is in septic shock, then again, we have to choose which carbapenem. And I think all of you may know this, but you must understand the subtle differences between the carbapenems. So for example, when you're talking about IMI and MIRO, their spectrum is almost the same, except that gram-positive activity is a little better with imipenem, especially activity against Enterococcus fecalis. But the downside is that imipenem has a higher tendency to produce seizures, and it is not recommended if the patient has a CNS infection, has renal dysfunction, or prior seizure history. And sometimes, you may get differential sensitivity to IMI and MIRO. So, because while both of them get inactivated by carbaphenemases, you have porin mechanism working for IMI and efflux mechanism working for MERO. So sometimes in your report, you will find that meropenem is resistant, but imipenem is sensitive. Then maybe you can use imipenem, but you have to be very careful in these patients because sometimes it may not work. Then ertapenem, it's commonly used in adults. It does not work against Pseudomonas and Acinetobacter. It should never be given in patients who are in the acute septic state. It is mainly a drug which you switch over to later if you are sending the patient home. Or for example, there is a patient who has an ESBL osteomyelitis and you have to give him 6 weeks therapy. Then you can use ertapenem. But remember that in children, ertapenem has to be given twice a day. Not once a day, because in adults you give 1 gram once a day, but in children you have to give 20 mg per kg twice a day. So again, there is not great benefit with ertapenem because still it will have to be given twice a day. And doripenem again has no advantage over IMI and MERO, and therefore if an isolate is resistant to IMI and MERO, doripenem will definitely not work and we should not be using this drug. So your choice, most of us in clinical practice actually use a lot of meropenem followed by either imipenem or ertapenem. Now, let us come back to our case because I had discussed about management of ESBL infections. So our patient had an ESBL infection, but patient was not in septic shock. And the BL-BLI MIC was okay. I mean, of course, the Piptaz MIC was 8, but it was not 16. And your cefoperazone sulbactam MIC was also 8. So you can choose ceftriaxone sulbactam as twice daily therapy, because in this patient, you will have to probably continue with parenteral antibiotic only because the patient is also resistant to cotrimoxazole. So you can't give cotrimoxazole on follow-up. Now, there is no need to add aminoglycoside to BL-BLI. So please remember that if you are using either BL-BLI or carbapenem alone, they are enough. You don't need to add an aminoglycoside. But the other question which may be there in other people's mind is that can we use amikacin monotherapy in our patient? Because this patient has a ESBL coming from the urinary source. So yes, you can use amikacin monotherapy in this patient and then discharge him on amikacin. But remember, if this patient has a high creatinine, if the patient has underlying renal damage because of VUR or something, then it would be preferable not to use an aminoglycoside. You cannot use aminoglycoside monotherapy for treatment of ESBL bacteremia from non-urinary sources, like coming from a central line or coming from the abdomen. You can't use amikacin. And if you decide to use amikacin, please use amikacin alone. There is no point using ceftriaxone plus amikacin because anyway ceftriaxone is resistant. And there is this guideline, which I would refer all of you to read, which has just come out in 2022, which is IDSA guidance on the treatment of antimicrobial resistant gram-negative infections. And I think it's a good guideline. Now, moving from ESBL infections, let us go on to a little more complicated case. This is a 5-year-old who has acute lymphoblastic leukemia, and the patient is on consolidation chemotherapy. The patient has febrile neutropenia. The ANC is 200. And the patient's blood cultures are sent, and the treatment is initiated with cefoperazone sulbactam and amikacin as per unit policy. Now, different units have different policies about managing febrile neutropenia. So, our unit, we use cefoperazone sulbactam and amikacin as the first line. However, if we have a patient who comes very sick in septic shock or who has a past history of resistant bug or who has received these drugs recently, then our empirical therapy is meropenem with colistin. Now, this is the report which comes to you after 48 hours, and you find that this patient has grown Klebsiella pneumoniae in the blood culture. And if you look at the sensitivity, you find that amikacin is intermediately sensitive. Then your colistin is sensitive. Your tigecycline is sensitive. And phosphomycin is resistant. I mean, it was not there, but I've put it here. And what is very important is, apart from looking at this, you have to look at the MICs. Because when your carbapenem is resistant, see what is the carbapenem MIC. Now, if you look at this, your meropenem MIC is more than 16. So it is clearly resistant. Your imipenem is 2. And we know that what are the breakpoints? The breakpoints are 1 or below is sensitive, 2 is intermediate, and 4 is resistant. So by that criteria, imipenem is also maybe a little bit more sensitive than meropenem, but usually you can't rely it in a neutropenic patient. So now the question which is there in your mind is, if you have a bug like this, how are you going to treat this patient? Will you use colistin and high dose meropenem or high dose imipenem? You can't use imipenem in high doses because, as I told you, it gives seizures. Will you use colistin and tigecycline? But remember that the tigecycline MIC is 2. And I told you earlier that if your tigecycline MIC is high, it may not work. And the third is that, are you going to use colistin and amikacin? Because amikacin is intermediate, but remember that, colistin is nephrotoxic, then amikacin also becomes nephrotoxic. So here you have to treat a carbapenem resistant Klebsiella pneumoniae, and we have to choose the best drug combination. So before we go to choosing the drug in this patient, we have to understand something about the treatment. So polymyxins are the backbone of treatment, but you never use polymyxins alone. You use combination therapy. Why do you use it as combination therapy? Because polymyxins don't penetrate very well. They don't go into the lung well, they don't go into the CNS, they don't go into the bone, they don't go into the urine. And you have emergence of resistance to polymyxin. And the most important thing is, because people have started realizing the drawbacks of polymyxin, now the labs will not report polymyxin sensitivity as S. It will either show you I or R, never S. And the reason for this is that because polymyxins are not great drugs. And one more thing which is very important is that if you get a Vitek sensitivity of the polymyxin, you have to ask the lab to do a broth microdilution or BMD, because sometimes by Vitek you can get a wrong report. So you may have a resistant colistin isolate which will be called as sensitive. So you have to ask for BMD. But as I said, that you can't use the drug alone. So you have to combine it with various drugs and the various options. What are your various options? Like carbapenems or tigecycline, minocycline, or phosphomycin, or aminoglycosides, or TMP, SMX, or that drug ceftriaxone, sulbactam, EDTA that I talked about. These are your companion drugs, and also ceftazidime, avibactam is the other drug. So we'll come to that a little later. Now, how will you choose which drug to give? So when we talk about polymyxin, the best point about the polymyxin is that they are active against all the top gram-negative bacilli which are there in your ICU. So it works for E. coli, it works for Klebsiella, it works for Acinetobacter, it works for Pseudomonas, it works for Enterobacter. What are the drugs? What are the pathogens for which it doesn't work? It doesn't work for Serratia, it doesn't work for Providentia, it doesn't work for Proteus, it doesn't work for Burkholderia. So there is quite a good amount of scientific data with polymyxin. And please remember that Polym B is better than colistin, because as pediatricians, we are always used to giving colistin, but there are problems with colistin because, one, it is a prodrug. So once you give the colistin, it has to be converted to the active drug in the body, which takes time. And if you have a patient with severe sepsis, then it may not work immediately. Second is there is batch-to-batch variation of colistin. And the third is the first pass effect, that when you give colistin, 2/3 of the drug is actually excreted unchanged into the urine. So you always have to give a loading dose. Therefore, the advantage of Poly B is that Poly B is a drug in itself, so it's not a prodrug. Second, there's no batch-to-batch variation. Third, that the drug has lower nephrotoxicity as compared to colistin. And fourth, that you don't need to dose modify in case there is nephrotoxicity. So, but the only disadvantage of Poly B is that it does not go into the urinary tract. So if you have a UTI because of carbapenem resistant gram-negative bacteria, you have to use colistin. You can't use Poly B. And the other disadvantage of Poly B is neurotoxicity. Basically, you can have seizures, and a lot of children will complain of, tingling around their mouth. And that's a common side effect. And another thing which you will see with Poly B is hyperpigmentation of the patient. So patients will really become very dark. But as I told you, that though polymyxins have these advantages, their cons are that they don't penetrate at various sites, and they also have this nephrotoxicity and neurotoxicity. Now, what about carbapenems? Carbapenems earlier it was thought that even if carbapenems are resistant, they will work because of synergy with polymyxins. So, once you give a polymyxin, the polymyxin will damage the cell membrane and the carbapenem will enter into the cell. But we know that carbapenems will work only if the MIC to the carbapenem is 8 or less. And if you actually see in our country or in our labs, most of the MICs are more than 16. So therefore, it is not really a good drug to use, and it also there's a huge cost associated with it. So unless your carbapenem MIC is 8 or less, do not use high dose carbapenems. Now, what about tigecycline? Now, the tigecycline has activity against most gram-negative bacteria. It does not work for Pseudomonas. The other advantage of tigecycline is that it works for MSSA, it works for MRSA, it works for Enterococcus, it works for anaerobes. So TIGI is a good drug, and especially good if you're thinking of intra-abdominal sepsis or skin and soft tissue infections, because there it penetrates well. But the problem with tigecycline is that the MICs are rising, and if your MIC is more than 1, it will not work even if you use a double dose, which in adults is 200 stat and 100 BD, and in children we use a loading dose of 4 mg per kg and then 2 mg per kg 12 hourly. It does not achieve good levels in blood, lung, urinary tract, and brain. And there are a lot of side effects with tigecycline, especially vomiting, and it can cause coagulopathy, it can cause thrombocytopenia, and it can cause liver dysfunction. Now, minocycline is another drug which works like tigecycline. The only good thing about minocycline is that it achieves better levels in the blood as compared to tigecycline, achieves better levels in the lung. But the downside is that most of our isolates are actually resistant to minocycline. And the only pathogen for which it may be considered over TG is Acinetobacter. Now, what about fosfomycin? Fosfomycin is a good drug. It penetrates at all sites. And it's such a small molecule that any organ it will penetrate. And it's mainly active against E. coli and some Klebsiella. How it is not active against Acinetobacter at all. It is not active against most Pseudomonas isolates. It works for both MSSA and MRSA. It works for Enterococcus faecalis, but it does not work for anaerobes. So remember that fosfomycin is again a drug not for empiric therapy. It is for definitive therapy once you get a report which says that your fosfomycin is sensitive. The other problem with fosfomycin is that there is rapid development of resistance, so you can't use it alone. And then there are side effects like hypernatremia, diarrhea, fluid overload, hypokalemia, which are particularly difficult to handle after the first 4 to 5 days of treatment. What about amikacin? As I said, the pro is that its sensitivity is better than carbapenems. But the problem is that there is additive nephrotoxicity with poly B. So you can't really use a combination of colistin and amikacin unless you're pushed to the wall, because otherwise the patient's kidneys will definitely give up. What about cotrimoxazole? So you can rarely see isolates which are carbapenem resistant but cotrimoxazole sensitive. But basically cotrimoxazole is only a drug for E. coli. It doesn't work for any of the other pathogens like Acinetobacter, Klebsiella, or Pseudomonas. So only if you have a carbapenem resistant E. coli which is sensitive to cotrimoxazole, you can use it. And as I said, what about ceftriaxone sulbactam EDTA? That it has good in vitro efficacy. It works for NDM producing infections, but there is no in vivo data. So maybe if you have a patient with a carbapenem resistant infection in which the patient is not sick, like the patient has just a urinary tract infection or something, you can try using ceftriaxone sulbactam EDTA alone. But in other cases, you can't use it alone, but you can use it as a companion drug, because suppose you have a patient who has a carbapenem resistant infection and you're giving poly B and you don't have any other drug to give along with poly B because everything is resistant, then maybe you could use this drug. Now, when we come to our patient, the same patient I was talking to you about, the patient is sick, the patient is neutropenic, the patient has an XDR Klebsiella with a tigecycline MIC of 2. So colistin with tigecycline may not do the trick. It may not be the best option. So should we keep any other option in mind? And that is where this ceftazidime avibactam comes in. Because I do adult ID along with pediatric ID, this agent has almost completely replaced polymyxins in adults. And I think the time will come when it will also become very commonly used in pediatrics. So to understand ceftazidime avibactam, you have to understand a little bit about the various kinds of carbapenemases. So these beta-lactamases or carbapenemases can be divided into various classes. And all these red are actually the carbapenemases, whereas these are basically the ESBL like CTS, XM, SHB, etc. So you have class A carbapenemase, the most important of which is KPC. You have class B, for us the most important is NDM. And then class D, most important for us is OXA. So in India, basically we see mostly either OXA or NDM. So 25% of your isolates are OXA48. In 50%, you have OXA48 and NDM, and in 25%, you have only NDM. And these are mainly the ones which are produced by E. coli and Klebsiella. So E. coli mainly produces NDM with or without OXA, whereas Klebsiella produces mainly OXA with or without NDM. Now, so you have to, if you want to understand the activity of the various new BL-BLI combinations, I'm not going to talk about this Meropenem, Veborobactam or Imipenem Relibactam here, but let us focus on ceftazidime avibactam. So ceftazidime avibactam will work for ESBL, it will work for MC, it will work for OXA, it will work for KPC, but it will not work for NDM. And that is why it is not a great drug for us in India, because we have a lot of NDM, whereas in Europe, where they don't have any NDM, it's a great drug. Now look at this drug called Aztreonam avibactam, which is still in clinical trials. It works for ESBL, AMC, NDM, OXA, KPC. So ideally, we should be having this drug for our country because we have a lot of NDM. But because we don't have this drug, we have ceftazidime avibactam separately and we have Aztreonam separately. So if you use ceftazidime avibactam with Aztreonam, technically you are using Aztreonam avibactam. And that is how we are treating many of these patients who are co-producing NDM and OXA with this. And of course, cefiderocol is another drug which is, you can import it if you have a rare patient who is resistant to everything. It works for E. coli, Klebsiella, Pseudomonas, Acinetobacter, and its mechanism is different from the other drugs. And it takes care of other resistant mechanisms also. So if an organism has become resistant by, by porin or efflux, cefiderocol will work. So remember, for E. coli and Klebsiella, these are new guidelines from the ICMR, which say that if you have E. coli or Klebsiella, which is carbapenem resistant, then you check for ceftazidime avibactam susceptibility. If your ceftazidime avibactam is sensitive, use that as monotherapy. You don't need to give anything else. If your ceftazidime avibactam is resistant, then you do a synergy test with Aztreonam, and I'll tell you how it is done. So now the treatment of choice for E. coli and Klebsiella, which are carbapenem resistant in adults, is Cas-Avi with or without Aztreonam. And we have migrated completely from a poly-B based regime to this regime. Of course, remember that this combination is not going to work for Acinetobacter, and it is not going to really work for Pseudomonas also. So it is primarily for E. coli and Klebsiella, and you can't use it as empiric therapy till you know what your agent is. So in this patient, Cas-Avi was susceptible, and therefore, instead of giving all this masala of poly-B with tigecycline, etc., you can use Cas-Avi alone. The adult dose is 2.5 grams given over 2 hours over 8 hourly, and in children, you can use a dose of 50 mg per kg 8 hourly of ceftazidime avibactam and this. Now, let us look at another isolate we've had recently, again in a child who's a cancer patient. Now, this patient has grown E. coli in the blood. And if you look at this E. coli is carbapenem resistant, but at the same time, it is sensitive to colistin. It is sensitive to, ideally this should be written as I, not S. Gentamicin sensitive, amikacin sensitive. It is sensitive to tigecycline with an MIC of 0.5. It is sensitive to minocycline. It is sensitive to fosfomycin. So unlike the previous case where you really didn't have many options, in this patient, you have options. Now, what are you going to choose? So as I said, never just think of colistin alone. Think of colistin versus poly-B, because I've already told you what are the advantages of poly-B therapy. So you can combine colistin, poly-B and tigecycline. Okay, you can combine this with fosfomycin because fosfomycin is sensitive. You can also combine this with minocycline because minocycline is sensitive. And remember, if TIGI and Mino are both sensitive, then Mino is always a better drug than TIGI because it achieves much better levels in the blood and it has fewer side effects. What about using tigecycline and fosfomycin or tigecycline and amikacin? I mean, remember that tigecycline is not a good drug for bacteremia. So you shouldn't be using any of these combinations with TIGI. I mean, you should, because tigecycline you should use only if you don't have any other options. So when you have other options like fosfomycin, minocycline, sensitive, then you would combine your polymyxin B or colistin with them. Though aminoglycosides are susceptible, you would not use them. Now, but can we use Cas-Avi in this patient? Because as I told you that in E. coli or Klebsiella, if Cas-Avi is sensitive, that is the drug of choice. So in our patient, we did an expert carba. So one way to know whether Cas-Avi will work or not is to do an expert carba. So if your expert carba shows that NDM is also there and Oxa is also there, you know that Cas-Avi will be resistant because Cas-Avi works for Oxa and it doesn't work for NDM. So you can also actually do a synergy test, which is now being done. This is courtesy Shweta, my microbiologist friend. We did this test. So what you do is you take this solution and you put a disc. In one, you put a disc of Aztreonam. Here, there is no disc. Here you put a disc of ceftazidime avibactam, and in this you put both the discs. So if you can see, this solution is clear. It means that if you are combining Aztreonam and ceftazidime avibactam, there is synergy for that E. coli, even if Cas-Avi is resistant. So in this patient, rather than using poly B-based therapy, you could actually also use Cas-Avi and Aztreonam. So this is just to sensitize you to the fact that now these are other options which we have for treating our carbapenem-resistant pathogens. But let us look at something like this. This is a patient who's a 2-year-old boy who's currently admitted with us, who after neurosurgery got an Acinetobacter meningitis and bacteremia. And now if you look at this, it doesn't show up very well, but the only agent to which this isolate is sensitive is colistin. And it shows intermediate sensitivity to tigecycline, means the tigecycline MIC is 4. So tigecycline to kaam karne wala hi nahi hai. So how are you going to treat this patient? Because this is Acinetobacter. Your Cas-Avi Aztreonam combination will also not work. So unfortunately, in this patient, we are using just colistin alone, IV, and we are using colistin intrathecal therapy, because that is another thing. If you have a CNS infection due to a carbapenem-resistant bug, then you have to use local intrathecal therapy as well. And we are giving him IV colistin and intrathecal colistin also, because that's the only drug which we have for treatment of such a patient. So I have spoken to you about gram-positive pathogens, and now quickly in the next 10 minutes, I'm going to, can I take 10 more minutes, please?
Yes, Tanu, you can.
Okay. So that was about gram-negative infections, where I talked to you about how you're going to treat ESBL and how you're going to treat carbapenem-resistant bugs and how you're going to decide, and also to sensitize you that now there are options for non-polymyxin-based treatment as well. So now coming to gram-positive pathogens. So let us say you have a patient with MRSA bacteremia in your ICU, and this is your susceptibility. So you have Staph aureus. So the first thing which you need to look at is your oxacillin. Now oxacillin is resistant. So that means this is MRSA. Now you have so many other drugs to which there is sensitivity. So now the question in your mind is that, okay, this is MRSA. How are you going to choose between your various options? Like, are you going to use vancomycin? Now, if you're going to use vancomycin, you have to look at the vancomycin MIC again, because your lab will call vancomycin sensitive if your MIC is 2 or below. But in real life situation, if your MIC is anything more than 1, vancomycin will not work. So like I said, you have to look at the piptaz MIC, tigecycline MIC, you have to look at the carbapenem MIC, you also have to look at the vancomycin MIC. So, you have to decide between vancomycin. Now, the other thing is there's this daptomycin, which we don't use so much in children. You have levonorepinephrine, which is a new drug. Again, we don't use in children. You have teicoplanin as an option. And you have other drugs like clindamycin, erythromycin, etc. So the most important thing is you have to look at the site of the MRSA. So if it is an MRSA in the blood, obviously there are some drugs you cannot use, but you can choose between these drugs. And how are you going to choose? So I'm just going to talk to you a little bit about what are the pros and cons of the various kinds of anti-MRSA drugs. So when you look at vancomycin, it is the gold standard for all sites of infection. However, there is some data to say that its penetration into the lung is not good. You have to give a loading dose for vancomycin in very sick patients, like a dose of 30 mg per kg. Then you ideally, in a critically ill patient, you have to look at the levels 4 to 5 days after starting treatment, but those levels are not easily available and the turnaround time is another 5 to 6 days. Then there is nephrotoxicity. There are infusion-related side effects. There is no oral switchover available for vancomycin, and it is difficult to give. So if you're giving vancomycin, you have to give it 6 to 8 hourly, and you can't continue that. So that is a main disadvantage of vancomycin. What about teicoplanin? Again, with teicoplanin, it is not FDA approved. That is why there's not so much of data. But unlike US, teicoplanin is used very extensively in Europe. And it is a highly protein-bound drug. It should not be given for endocarditis. Bacteremia, you can still give teicoplanin. And it is a good drug for bone and joint infections because it penetrates well into the bone and joint much better as compared to vancomycin. Also, the lung penetration of teicoplanin is better than that of vancomycin. So if you have an MRSA pneumonia, you would choose teico over vanco. And the other advantage is that you can give it once a day, so you can continue it as OPAT. Linezolid is bacteriostatic, so you can't use it for bacteremia or infective endocarditis. There are a lot of adverse effects with linezolid, like anemia, thrombocytopenia, etc., tingling, neuropathy, etc. But it is a good oral bioavailability, but it's a drug which should be reserved for TB. And that is why if you have other options available, don't use linezolid. So, please understand that for MRSA, you have other oral options apart from linezolid. So you have clindamycin. If susceptible, you can use TMP, SMX, and you can even use doxycycline. Clindamycin is bacteriostatic. You can use it for pneumonia and osteomyelitis and skin and soft tissue infections, but you can't use it for bacteremia, endocarditis, or CNS infections. And there's a side effect of C. diff associated with clinda. TMP, SMX is useful for skin and soft tissue, bone and joint infections, and it can be used also for CNS infections. So amongst all these drugs, linezolid goes well into the CNS and TMP, SMX goes well into the CNS, but the other drugs don't go well into the CNS. And of course, you have daptomycin, but it's a new drug. It is bactericidal. Another advantage of daptomycin is that it works both for MSSA and MRSA equally well. So if your lab tells you that you are growing GPC, but you don't know whether it is MSSA or MRSA, you can start with daptomycin. And it also acts by inhibiting the toxin production. So you don't need a toxin synthesis inhibitor for this. So it is a drug mainly for endocarditis, bacteremia, skin and soft tissue, bone and joint infections, but it doesn't go into the brain. You can't use it. It is destroyed by the surfactant. So you can't use it for pneumonia. And if your patient is on daptomycin, you have to do their CPK every week. And it can sometimes cause a eosinophilic pneumonia, which is a serious side effect of daptomycin, and the dose also varies according to the indication. And this is just what I wanted to show you is a meta-analysis which compared teicoplanin with vancomycin for bacteremias or other infections. And here you find, this is the final summary estimate, and you find that they are actually the same. So if you have a patient with MRSA bacteremia, you can use teicoplanin. If your patient has endocarditis, then you can't use teicoplanin. Then you will have to use either vanco or dapto. So that was about gram-positive. And then finally, I'm coming to azole-resistant candida, because that is also something which you are now going to see more often in your intensive care unit. So candida is a very common isolate in your PICU. I mean, every day, if you send endotracheal aspirates, if you send urine cultures, you will grow candida. But remember that candida is mostly a colonizer, and you have to be very careful that you don't go around treating the colonizer, because otherwise you will only increase the risk of azole resistance. But now it is also a pathogen, and now we are seeing more and more of Candida auris. So it is a highly resistant form of Candida, which is now spreading throughout the world. And the problem with Candida auris is that one, it is multi-drug resistant. Two, it can spread from one patient to the other. Like you can have spread of C. difficile from one patient to the other. Candida auris can also spread. So you can have an outbreak into your ICU. And most of the isolates of Candida auris are actually resistant to the azoles, and they are also resistant to amphotericin B. So you have to use echinocandins here. Now, again, as I said, in adult medicine or adult ID, Candida is almost exclusively treated by the echinocandins, whereas we in pediatrics don't use so much of echinocandins because we use, in newborns, we use amphotericin B or liposomal amphotericin B, and in other patients who are fluconazole sensitive, we use fluconazole. But now with azole resistance coming up, you have to use echinocandins. So to just give you a little bit of update about the echinocandins, because you are going to be using them more and more, that they are all more or less the same, whether you talk about Caspo, Mica, or Enedula. And they all act by inhibiting beta-D-glucan synthesis, which is a component of the fungal cell wall. So your azoles act by inhibiting ergosterol synthesis. Your amphotericin B acts on the cell membrane, but these act on a different mechanism. They are all approved for invasive Candida. They are all fungicidal for Candida. That means they are not fungistatic, they are fungicidal. Only if you have Candida parapsilosis or Candida lusitani that you can get high MIC. So if you have a Candida parapsilosis and it is sensitive to fluconazole, you would prefer fluconazole to the echinocandin. The biggest advantage of these drugs are that they have few adverse effects, they have few drug interactions, they are all given IV, and they all have to be given once a day. So they are very convenient to give. And remember that they don't go into the brain, they don't go into the eye, and they don't go into the urine. And that is why they are not commonly used in neonatal Candida, because in neonatal candidiasis, you have a lot of associated meningoencephalitis and you have urinary tract involvement. But in your PICU, you may have patients, older children who are coming with Candida where there is no spread to the brain or urine. And so they also have mainly they're excreted by the liver, and they're not excreted by the kidney, and they don't need any renal dose modification. So that means whatever be the patient's renal function, you use the same dose. They all have concentration dependent activity, and that is why you dose them once a day. They are all fungistatic for Aspergillus. So remember that they are not good drugs for Aspergillus. They are good drugs for Candida, because sometimes, a patient who has a lung lesion also, they put on echinocandin. So if it is, Aspergillus in the lung, then the echinocandin won't work. They have some activity against pneumocystis also. So in serious cases of pneumocystis pneumonia nowadays, we use combination therapy of cotrimoxazole with echinocandins. And remember that they don't work against mucor, they don't work against Cryptococcus, Fusarium, Scelosporium, Trichosporon, etc. Trichosporon is again another yeast, and therefore sometimes if your lab tells you that there is a yeast which is growing in the blood culture, don't always assume that it is Candida. It can even be Trichosporon, it can even be Cryptococcus, etc. And just to tell you that there's not much to choose between Caspo, Mica, and Enedula. Suffice to say that there is maximum data with micafungin, and the dose is quite high in newborns. You use a dose of 10 mg per kg per day, but in older children, you use 2 to 4 mg per kg per day. Whereas in Caspo, this is the dose, and Enedula has been recently approved in children, and the dose is 3 mg per kg loading and then 1.5 mg per kg per day. The biggest advantage with Enedula fungin has over the other two is that it can be safely given to patients with very severe liver dysfunction. And many of your patients, like your liver transplant recipients or patients with critical illness who also have liver dysfunction, then you can't use Caspo or Mica, then you have to use Enedula fungin. So you have to remember that when you have a case of candidemia in your PICU, obviously you will use fluconazole if it is sensitive, but if it is fluconazole resistant, then you have to choose between liposomal amphotericin B and echinocandin in an older child. And I think as per current data, it would be much better to use an echinocandin instead of liposomal amphotericin B, because liposomal amphotericin B is a toxic drug. It has other side effects. So you use an echinocandin. But apart from using drug therapy for candidemia, what is also very important is removal of the central line and repeating a blood culture. Like only for 2 infections, you want to repeat the blood culture after starting therapy. One is Staph aureus and the second is Candida. And basically in these two, you have to repeat a blood culture. And once the culture becomes negative, then you have to give for 2 weeks from the last negative culture. So I think I would like to stop here because I'm already 5 minutes over. I just wanted to kind of talk to you about these MDR pathogens. And I think the moderator will tell me whether this, I hope it was not too high, the level of the session. And now we have enough time to take questions and, solve other problems. And I think in the end, I would just like to give you a few messages here. That first, in the PICU, always get your empiric therapy right, because you cannot afford to give the wrong drug, because your mortality, your survival depends on that. Having said that, as soon as you choose your empirical therapy properly, but as soon as you get your culture results back after 48 hours, then you have to make decisions whether how you can optimize therapy, how you can de-escalate, how you may have to escalate therapy. And sometimes in some cases, when you can't really find any infectious focus and you've made an alternative diagnosis, how you can stop therapy. Apart from these things, there are some other principles which you must remember. That is sending cultures, source control, which is extremely important, because no amount of drug you can give, if you don't do source control, your patient won't get better. Please pay attention to the dose and always look it up, because always the first dose has to be the loading dose, no matter what the patient's creatinine is. And then if your patient has a rapidly changing creatinine, please remember to keep modifying the dose every day. And then finally, the duration of therapy is also very important, because now if you're going to use such expensive drugs and such high level drugs, there is no need to go ahead and keep giving 14 days of treatment for every infection. With the exception of Candida and Staph aureus, where you have to give 2 weeks of therapy, all other infections, you can actually treat them for as short a time as 7 days. And the moment you follow their procalcitonins, and once the procalcitonin has become 20% of your peak level, you can actually stop therapy. So you hit hard, give the best possible treatment, but then de-escalate and cut short the duration. I think with that, I want to stop now and take questions.
Thank you, Tanu, for the wonderful talk. It was quite crisp and clear. And I don't think so it was quite extensive or quite beyond what is required for an intensivist. You have pretty much covered the basics, I could say, where every intensivist should know that these should be considered, especially things like you'll have to give a broader spectrum at the outset when the child is sick, and then try to de-escalate or based on your antibiogram. I think it was quite elaborate. I found it's very useful. Many practical tips you told. Every slide had 1 or 2 practical tips and how to go about. So I have one question here from the audience. Is fosfomycin a good only for UTI, or is it useful for both blood and pneumonia?
So remember that fosfomycin comes as 2. One is oral fosfomycin, which are oral granules. And that is basically a drug which is given for lower UTIs like cystitis, prostatitis. So we should not confuse the IV fosfomycin with that. What we talk about is IV fosfomycin, and that works actually very well for infection at any possible site. And that is dose different. You can't use the oral fosfomycin granule as a replacement to IV fosfomycin.
Additional drug to polymyxin, right? What you said for bacteremia based on the sensitivity pattern.
Yes. So it is a good drug to combine with polymyxin, because if fosfomycin is sensitive, that would be the drug you would prefer as compared to tigecycline or anything else, because one, it penetrates all areas very well. It's an effective drug. The only downside to fosfomycin is that one, there is development of resistance, and second is after 3 to 4 days now, your hypernatremia and other things become quite challenging. So that is the only downside. But you can't use it as empiric therapy. You can only add it to the regime once your sensitivity, you know that your organism is either E. coli or Klebsiella, because it mainly works for these 2 pathogens. It doesn't work for the other gram-negative pathogens.
Yeah. So most of these drugs have high sodium load, isn't it? Most of the drugs, piptazo, fosfomycin, most Almost
they
all.
all have, but in clinical practice, the sodium, problem is more with fosfomycin, not so much with the other drugs.
Okay. So there's another question in Acinetobacter species. It's a big issue these days, and pan resistance. What is your suggestion? What do we do about this?
So that is a good question because, I showed you that one case, while for E. coli and Klebsiella, you now have so many options. For Pseudomonas also, at least, you have phospho may work in some patients. For Acinetobacter, unfortunately, there is nothing. So Acinetobacter, as I said, our main drug is still polymyxin. Now, then you have to think of giving local therapy. So if you have an Acinetobacter VAP, you should use colistin nebulizations. If you have Acinetobacter meningitis, you have to use colistin intrathecal. Then you can look at sulbactam sensitivity because if it is, so one way to look at it is to look at the cefoperazone sulbactam susceptibility on the report. So many times you will find that carbapenem is resistant, piptaz is resistant, but cefoperazone sulbactam is pronounced as intermediate. So that should make you suspect that there may be sulbactam which may be working, and you can use plain sulbactam there. You should check for minocycline susceptibility because if minocycline is sensitive, you can add that to the regime. But in other cases, what we do is to give polymyxin along with this ceftriaxone sulbactam EDTA combination because there is nothing else that you can use. Then you use this as a add-on drug to Acinetobacter because one is that the EDTA is like a breaker, circuit breaker, and second is that the sulbactam also has some activity against Acinetobacter. Now, I just want to tell you that there is a new drug in the pipeline which Cipla may bring, which is called as some Darlobactam combination. Darlobactam with some, I've forgotten the name. But that is a drug which is specifically effective for Acinetobacter. So if it comes into the market, then that may be a drug which is available. But for now, it's only polymyxin.
Thank you. I just have a question. We often, not so often we see this heteroresistance in gram-positive infection. So is it common or as common as in gram-negative infections as well?
So heteroresistance is mainly described with colistin and amongst the gram. That is why, there is an issue with this thing. And you can sometimes see in cases of Staph aureus. So one of the ways to pick up heteroresistance is actually to carefully look at the MIC. Because if there is an element of heteroresistance now, you will find that your MICs are on the higher side. So if like you have vancomycin MIC creep, you will find that your vanco MICs are actually 2. So the lab will also call it as sensitive, whereas actually vancomycin is not going to work. And that is a problem because if your vancomycin MIC is 2, your teicoplanin may also not work and your daptomycin may also not work because vancomycin and daptomycin resistance go hand in hand. So we must also understand that now you have other drugs as well for MRSA, which I didn't discuss in my talk, like you have ceftaroline. Ceftaroline is a drug brought in by Pfizer. It has excellent activity against MRSA. Then another is levonidifloxacin. So these are the other 2 drugs which you can use in some patients who have high vancomycin MICs where your dapto is also showing resistance.
What about
and phosphomycin also. Phosphomycin is an excellent drug for MRSA and MSSA. So if you have no other option, and the dose of phosphomycin which you give for staph gram-positive infections is half the dose for gram-negative. So we have used in some patients phosphomycin as well.
How about tigecycline?
Tigecycline is not a good drug because one is that, it's too broad spectrum. So if you have found that you have an MRSA, then why would you like to use tigecycline? Because it has activity on so many other pathogens. And second is that it is not good in blood. So there's actually, tigecycline may have a role as empiric therapy, but once you know that there is an MRSA, then tigecycline has no role. Then you should take it off and you should replace it with a more narrow spectrum narrow spectrum drug. Tigecycline, I think, has now gained more importance for enterococcus because you will now start seeing more. We've seen patients who have had enterococcus sepsis, which is even resistant to linezolid, vancomycin, and teicoplanin. And often the only drug which works is tigecycline. So there you may have to use tigecycline. So it's not really required for MRSA, but more for Enterococcus faecium.
Okay.
About the CNS resistant infections, issue is about the penetration of blood-brain barrier. Now, all those beta-lactamase inhibitors, is it sacrosanct that they don't penetrate at all, or there is some exception to the rule?
Yeah, it's a good question. So, and the problem usually comes when you have a resistant gram-negative. So, for example, a carbapenem-resistant Acinetobacter or E. coli or Klebsiella in the brain. So then your option is only colistin-based therapy, which doesn't go into the brain. If fosfomycin is there, then it's a good drug because it penetrates the brain. Now, Cas-Avi. So basically, Cas-Avi is a drug where, again, if you look at the data, it says that, Cas-Avi, the avibactam doesn't go. But we had one patient. I don't know if there's somebody from, our department who's hearing this lecture. This is a child who came with Klebsiella meningitis. And we treated him only with Cas-Avi because colistin was also resistant and he cleared his meningitis. So only monotherapy. So, I mean, it's just like an off-label use, but yes, that is, you may consider using it in some patients with meningitis, because otherwise you will have to kind of do intrathecal and give colistin, or you'll have to put an Ommaya reservoir and give colistin through that.
But there again, you will be using colistin. You won't be using BLBLI, or you won't be using avibactam combination. Suppose you give intrathecal.
So intrathecal, you can't use BLBLIs because you can't give these, but we've used tigecycline intrathecal. So we've had 3 or 4 patients who had a resistant gram-negative infection in the brain and they did not get better with intrathecal colistin. Then you can use tigecycline as intrathecal therapy. So for intrathecal administration, you have an option of amikacin, you have an option of colistin, and you have an option of tigecycline. You should not use polymyxin intrathecally because it's more irritant. And another important thing is that when you give an intrathecal agent through the EVD or something, you must clamp the tube for some time, because otherwise, you may not be able to, even colistin needs conversion because you give it as colistin ethate. It has to be converted to colistin in the body by spontaneous degradation. So that is also you must remember.
And what about resistant gram-positive MRSA CNS infection? Suppose you've got an infected shunt or something and getting MRSA.
So you will have to, you'll have to remove the shunt. That is very important. And then you can use vancomycin, because vancomycin is okay. I mean, so far the gold standard of therapy for MRSA brain infection is vancomycin. If cotrimoxazole is susceptible, you can use cotrimoxazole because it penetrates the brain very well. Another option is to use linezolid, because linezolid has better CNS penetration than vancomycin. So you could use linezolid also.
In that case, you use higher doses or use the same doses?
Same dose, 10 mg per kg 8 hourly. It is not there in the guidelines because they will still talk about vanco, but we have used both linezolid and cotrimoxazole for brain infections with MRSA.
So in the pediatric use of ceftazidime avibactam, what's your experience? You said predominantly it's used in adult. I'm sure pediatricians.
But now we're using it a lot. For the past 1 year, in our cardiac surgery patients, even in our NICU, even in our PICU, and we've got excellent response, even in our febrile neutropenics. So it is not yet approved for children, but I think it will take some time to get approved. But what I'm just trying to tell you is that keep your mind open. Don't go just the colistin way. Always ask your lab. If it's E. coli and Klebsiella, please do Cas-Avi susceptibility. And if Cas-Avi is sensitive, use it as monotherapy. It will work very well.
We have been moved to ceftazidime avibactam most of the children as well. So yeah, we are coming away from polymyxin, as you said.
Yeah. So
you're doing expert carba?
No, now we have not doing expert carba because we do direct sensitivity testing. So that was when, we didn't have the expert carba, we didn't have sensitivity testing. Now you have a E-strip for Cas-Avi. So you can do a E-strip testing. The problem is, why expert carba is not a good thing, because you may have other mechanisms of resistance also operating, which suppose your expert carba is showing that there is OXA48 only. then you know that Cas-Avi will work. But what if there is a Porin mechanism? What if there is a efflux mechanism operating? So it is always good if you have a direct sensitivity test which tells you that it is sensitive. And also now if you want to use Cas-Avi plus Astronam, you do the synergy test.
Only thing is, it may take a while to get the report sensitivity rate based on the E-strip, all those. So in that case, can we do the expert carba where we get
No,
this?
so what we do is that if you are growing E. coli or Kleb, suppose your lab tells you that you are growing GNB and it is a lactose fermenter, then we know that it is E. coli or Klebsiella, then we start this patient on a combination of Cas-Avi and Astronam, okay, both. And then once your sensitivity comes back, then we take the Astronam off. That is something which you can do.
Yeah. I don't find anything there.
One more thing which you must understand is that when you are doing an expert carba, you have to be sure that you are dealing with E. coli or Kleb. Because sometimes what people do is that the culture flags, the bottle flags, GNB there, you do an expert carba from the GNB, from that bottle. And it shows that nothing is present or oxa is present. But what if it is Acinetobacter or Pseudomonas? Okay, so if it is Acinetobacter or Pseudomonas, you cannot rely on expert carba. So for us to rely on expert carba, you need to know that it is a
Enterobacter.
coli or Kleb. So in that case, it is better to do a BCID panel from the blood culture, because if you do a BCID panel, it will tell you what gram negative it is, and it will simultaneously tell you what are the resistance mechanisms, because the BCID2 panel includes all these. It includes your it includes NDM, oxa, everything. So then you can do that instead of expert carba.
Yeah. Yeah, there are no more questions in the chat box. I thought that was an amazing talk, Tanu. It was really eye-opener, many things. You enlightened us in many ways. So anything, Mahesh, you have anything to ask?
Just gram negative, your molecule you said.
Huh?
Your molecule you said, I mean, I just skipped your molecule, which is not available here. What you said, gram negative coverage?
Yeah, just 1 minute, I'll just tell you the name, just 1 sec. It's called as Darlobactam sulbactam. Yeah, Darlobactam sulbactam is the name. There is a trial which was done, which is called as the ATTACK trial. In fact, yesterday only we had a meeting with Cipla where they wanted to kind of know whether they should bring this drug into India. And I said, you definitely should bring it, because we see a lot of Acinetobacter and there's nothing you can give to these patients. So Darlobactam and sulbactam combination.
And one more standalone molecule you said, not BLBLI. The last one you said.
Cefderichol. Cefderichol is we have used it, but it has to be imported, and it's quite expensive. But we had a baby, who had a newborn baby who had colistin resistant Klebsiella. And at that time, I think it was Cas-Avi resistant, and even the patient didn't respond to that. So that was 2 years back. So we used Cefderichol. So that is the other drug. And there's a new drug which is going to come in pediatrics, is Tiapen, Tebipenem. Tebipenem is an oral carbapenem. It has its spectrum, which is same as meropenem and imipenem. So for switchover therapy for UTIs, you can use it.
Yeah, they are talking.
It is not the same as Pharopenem. Pharopenem's name sounds like this, but it is not this.
But Pharopenem, I mean, what's your take on that? Pharopenem is being really promoted aggressively.
Yeah, and nowadays a lot of companies are coming out. Unfortunately,
Yes.
You don't have data whether it works well for ESBLs. You need that kind of data, because otherwise, you are doing disservice to the patient, because patient को आप दे रहे हो सोच के कि वो ठीक हो जाएगा, वो patient ठीक नहीं होता. So, but Tebipenem is different. Tebipenem, there is good data that it works for ESBL. So it may be a good option for switchover therapy, especially like for cholangitis, for urinary tract infections, abdominal sepsis, etc.
The Tebipenem is available commercially in India very easily, right?
So which one?
Tebipenem, you said.
Tebipenem, not in India. It's available in Japan, but I think it will come in soon sometime.
Okay. Great.
There are some more questions.
I'll take it. Yeah, somebody's asked, do we always need dual therapy for Pseudomonas and Stenotrophomonas. Yeah, in an intensive care unit, we used to talk whether Pseudomonas, which with the sepsis, should we give combination therapy?
That was true when we were using ceftazidime earlier. But now, when you suppose you're using carbapenems or something, you don't need to give dual therapy. You can use a single drug. And unfortunately, beggars can't be choosers because you will not find a second drug to give to that patient. So that thing of combination therapy is mostly for the enterobacterials, E. coli and Kleb, not for Pseudomonas. So Pseudomonas, you can use single therapy. You have Cipro sensitive, use Cipro. You have ceftazidime sensitive, you use that. If you have carbapenem sensitive, use that, or you use colistin. The question about stenotropho is interesting. But the pest drug, we generally treat it with monotherapy because it's a low virulence organism. Minocycline is an excellent drug, and cotrimoxazole. So these are the two good drugs which you can use, followed by the quinolones for Stenotrophomonas.
Plain ampho versus liposomal ampho in CNS infections.
Liposomal ampho is better because there is data to suggest that liposomal penetration is better. So while in a newborn, you use amphotericin B deoxycholate because there the advantage is that it goes into the kidney, which your liposomal ampho will not go. If it is the brain, then you use liposomal ampho B. Because remember, if you have a CNS Candida infection, then the only two drugs which you can really use are amphotericin B and fluconazole. Echinocandins you can't use because they don't go into the brain.
And then asymptomatic candiduria, polymyxin B, any role in NDM? And should ask
so polymyxin B is same as colistin. Na? So all your NDM producing bugs will be sensitive to poly B. So wherever you're using colistin, you use poly B instead and C. And we don't need to treat asymptomatic candiduria but you have to understand that it is indeed asymptomatic because sometimes if a child has candiduria or you have isolation of candida from multiple sites like the trachea or the urine, you have to be sure that you're not dealing with invasive candidiasis. So that you have to be careful. So
and
then
treat
the patient you are
will be the same message for your.
Sorry? Hello, lost you.
No, go ahead.
No, so what I'm saying is that
go ahead, I said.
You have to treat it only if you think that the patient has invasive candidiasis and the candida in the urine is a reflection of that. Otherwise, you have to remove the catheter, stop the antibiotics. Those are the strategies which you have to use. Even giving fluconazole does not alter the outcome.
Same strategy for immunocompromised patients also. You have got the leukemia patients and other immunocompromised. Same strategy will be there for them also.
Yeah, now the recommendations have changed. So they don't say that you should give candida treatment even in neutropenic patients if it is coming from the urine. The only indications are urological intervention. So that is very important for us to know that if you have a patient colonized with candida and you are going to instrument the urinary tract, you have to treat because otherwise you get something which is called as cuts, which is candidemia from a urinary tract source. I think it's done.
Take time.
I'm fine.
Yeah, done. Take rest. After Rajesh,
yeah, thank you, Tanu. I think you need some break. You've been continuously.
Yeah, take over.
Yeah, thank you, Tanu, very much. You've been continuously talking. You want to take a break? You want to say something?
No, I'm saying don't get worried by my cough. If there is any other question, I would be happy to take it. Yeah. But I think it's over on the chat box.
Yeah, there's nothing more left in the chat box.
Yes.
Yeah.
Okay.
Thank you very much.
Thank you, Mahesh, for giving me this opportunity.
No, we should call you at least once a year for the review. It's something like yearbook. We should be reviewing every year. Because so many things, so many new molecules are coming. And I'm sure people are using, but whether we go into that kind of depth of knowledge while choosing these newer molecules, we really don't know. But we have been hearing about this Avibactam and all those things. Yes, we have not yet started using it very regularly, But I'm sure time is not far away because your old guns are really getting, all those bullets are no more useful. So you will be using it. And it's for the audience, Tanu gives wonderful experience even on phone. I mean, make it a point to talk to him whenever there's a patient. With that, we do take an appointment, and wonderful learning always whenever we take her kind of opinion on any patients. So with that, Dr. Rajeshwari, please, we can do the wind up.
Yeah, thank you, Tanu, very much. Thank you, Mahesh, too, for organizing this excellent friend of PICU. It's really wonderful. Whatever you're doing this, something new, enlightening from the adult counterparts, we learn more from them than our own community. I think it's a really good initiative by you. Thank you very much.
Thank you.
Thank you, Tanu. Thank you very much.
Bye. Bye.
Bye.
Bye.